Today we'll be covering some skills from week 1, week 2, week 3, and week 4. I'm just going to kind of combine them into how I would do a full morning routine. From week 1, we did do all the precautions, but we did not go over how to utilize a bed. In hospital setting or nursing home, we would have our side rails, which would have our buttons up and down for the bed, for the head, for the feet. Our call bell would be attached to the wall, and we would attach it to the railing here. In some situations, the foot panel contains all the controls, and the brake is found underneath. The bed always stays in a locked position unless we're moving it up to put it next to a stretcher or in a situation like that. So we covered all the safety operations. So for body mechanics, we have our patient here. We come in the morning, patient has moved down in bed. So we have our friction prevention sheet underneath our patient. We would look at our algorithms at the nurse's station to see how many patients or how many people are used to move this patient. Is it a 1 person, 2 person, possibly a lift? We would know that information prior to coming into the room. Upon entering the room, we would knock on the door, introduce ourselves, check 2 forms of identification with the patient, having them state their name and their date of birth, make sure it's the correct patient. I would perform hand hygiene in every situation coming into the room before I do anything with the patient, and always inform the patient of what you're going to be doing and why you're there. So for this patient right now, we are going to assist this patient in moving up in bed. We're going to ask the patient, are you able to assist? Are they able to raise their knees and help push up in bed? If they are not, that's totally fine. We would have them cross their arms. We would remove the pillow, move it to the top of the bed. We would both, myself and the person assisting me, would grab the friction sheet, and we would both go on the count of 3, going from a back to front motion. We would be telling the patient on the count of 3, she's going to tilt her head to her chest and have them cross their legs. Unless it's contraindicated in a patient who's had hip surgery or something like that, you don't want them to do an adduction of their legs, so they would just lay straight. We would count to 3, boost the patient up, realign the pillow under the head, put the side rails back up, bed in a lowered position because we would have lifted it to a working position, put blankets back on the patient, gave a call bell, asked if they needed anything else. If we were going to assist the patient to leave the bed into a chair, this isn't a wheelchair, but we'll pretend it is. We would put the wheelchair here. We would lock it. We would tell the patient again what we're doing, hand hygiene. I would use gloves if need be for any precautions, and these days I would be wearing a mask and gloves anyway. And so we would then pull the patient, again checking the algorithms, make sure I could do this on my own, or if I would need assistance of another person, or probably a Hoyer lift, something of that nature. I would pull the patient to the side of the bed. I would lift the side of the bed. I would put the railing down. I would have the patient roll on their side, and then when they were ready, I'd have them utilize the side rail to lift themselves up while I got their legs going here. After I let them sit a while, make sure there's no signs of dizziness, no tilt going on with their blood pressure, I would put a gait belt around the patient. I'd be holding it from the front. Here would be the wheelchair locked. We'd say on the count of 3, 1, 2, 3. I would assist the patient to a standing position. I would then inform them to take their arms, because I'm holding their knees with mine, over to the wheelchair to hold on for safety reasons. We would pivot, sit in the chair, and use their arms on the side to find a comfortable position. I would do the same exact thing for a person who is ambulating, except when they're ambulating, you would be lifting them up, you would put the walker in front of them, make sure that they were stable, and then once they had no signs of dizziness, no problems, you would stand to the side of them. Your gait belt would be in the back, you could hold it in the back, and you would tell the patient to lift the walker 12 to 18 inches in front of them and then walk into the walker. So let's get our patient back in bed. Let's see. Now, if we were taking a patient to get a diagnostic test that would require a stretcher, we would have 3 people. We would bring the stretcher in. We would let the patient know what we were doing. Again, we would ask that they cross their arms, cross their legs. We would line up the stretcher with the bed, but we would have the height of our bed up about 1 inch above the stretcher, so the gravity is going towards the stretcher. We would place the stretcher pad in between the crease of the bed. Count to 1, 2, 3, lift the patient over onto the stretcher thing, and then slide them on. That would be in one cohesive move. There would be one person over here holding up, giving a pushing move, and 2 people on that side, each doing a pulling move, while the patient, again, held her head up, feet crossed, unless it was contraindicated. And once they were in the stretcher, we would provide a pillow and a blanket and a call bell and any of their personal items that they would need before someone came in to transport them wherever they were going. So at this point in the morning, I would come into the patient's room, and before we did morning care, I would offer them a urinal or a bedpan. In this case, I don't know if this is a boy or girl, but if they said yes, for a male patient, I would have the handle up. I would place the urinal between the legs. I would place the penis within the urinal, and then I would elevate the patient's head, put a roll of toilet paper. I would leave the call bell, and I would ask the patient to call when they were finished. If it was a female, and we were using either a fracture bedpan or a regular bedpan, I would assist the patient in turning over. I would place the flat part of the fracture bedpan or the lower part of the regular bedpan about here in their back and slowly lower them back on. I positioned their legs to make sure they were directly over. And again, I would elevate the head to help in proper elimination. And then I would give a roll of toilet paper, a call bell, and say, call me when you're ready. When they were ready for me to come back in, when they were finished, I would, well, first I would ask if they were being measured for input and output, I would tell them not to put their toilet paper that they used inside the bedpan. I would have a little trash can right here for that because we wouldn't want that absorbing any of the urination if we were going to be measuring it after the fact. So after we came back in, I would either take the urinal or the bedpan out from under the patient. I would be turning them over. I'd be securing the bedpan while sliding it out to prevent any spills, at which time I would wipe the patient anything that they needed that they weren't able to get. I would place them back on the bed, cover them up, always providing for privacy every step of the way by shutting the door, pulling the curtain, using a blanket, any of those things. And then I would take the urine into the bathroom where I would be either putting it into a hat or anything that we were going to measure it in. And I would be looking for color, odor, consistency, and amount. And we would be documenting that after I performed hand hygiene, and then I would document. Okay, so after the patient urinates, we're going to get ready to give the daily bed bath before breakfast comes in the morning. So here's our patient. Mr. Jones, we're going to be forming a bed bath on you. So I have some wipes here. I would perform hand hygiene, and I would put my gloves on. And I will be using a separate wipe for every body part. And we will be starting at the face. I would see if the patient felt like they could participate in any way, doing any personal care, washing their face, washing their peri area, things of that nature, helping me put on my gloves. So we would start out with the face. I'm not going to use 1,000 wipes, so we'll just use one. And according to video purposes, we would fold in, and around, forming what would be a glove. We would start with the face, and we would do the eyes from the inner to outer canthus 2 times using different corners. Then we'd flip our wipe around, and we would do the other inner to outer canthus, again, flipping corners. You would want to do each eye twice. You would want to do the entire face, and then we would do the ears and the neck, again, switching wipes between body parts, and also letting the patient know that if at any time the bath water is to become too cold or uncomfortable, we can always heat up the wipes, we can always switch out the water. So we would start, again, face, head, neck, and then we would do the arms. We would do this side of the arm, and then we would flip over. I did forget that I was going to put my towel under there. I would be putting a towel under each body part. With the wipes, you don't necessarily need to dry, but if you were using soap and water, you would need to dry. So you would do the front part, flip over, do the palms of the hand, up the arm. You would do the armpits. Again, dispose, you would get another clean one. You would reach over now You would do the exact same thing to this arm, up, hands up, under arms, and then you would come back over here, and we would pull the blanket down and drape with a towel, another clean wipe. We would do the chest area, and then we would cover back up, always wanting to keep the patient warm. And if we had removed his gown, which we would definitely do for a bed bath, we would definitely be aware if there were any IVs or any kind of catheters in the arm. And if the gown did not provide for snap closures, we would have to take the tubing and the bag through the sleeve in order to get the gown off. Nowadays, most have gowns. So then we would be moving to the legs. Again, we want to wash the front of the legs first. Sometimes we might have to soak the feet if feet tend to get a little bit crusted. We would check the bottom of the feet. You never want to cut the toenails, but you could use a wood stick to clean underneath of them. You can use an emery board to get rid of any sharp edges, especially in the elderly at night. You wouldn't want to create any skin tears with, toenails sticking out, anything of that nature. And I should point out while doing this that in a normal setting, the entire time that I'm doing this, I would be doing my full skin assessment. I would be checking the skin for any lesions, for any signs of redness. I would be looking at any moles if they were irregular or something I didn't notice from the day before. I would be checking the creases of the skin under the breast, under the arms, under any adipose tissue folds where anything could get like fungus that would need like a nystatin type of cream. I would, be looking at the head. If there was facial hair, I'd be checking for any infestations, any scabs, anything of that nature. I'd be doing pretty much a general survey of the entire person, along with checking all areas of the skin for any type of breakdown, especially on the heels of the feet, on any bony prominence. When I got to the clavicle, I could pinch and check for skin turgor to see if there's any tenting, to make sure there's proper hydration. And I would go from this leg, ask the patient if they could lift up. I'd wash under this leg. Meanwhile, moving my towel from side to side. And then I would repeat everything on this side. After I was finished with the front of the body, I would have the patient assist in rolling over, and then we would do care of the back. Again, when I roll the patient over, I am assessing all of the skin. I'm assessing how they were laying. Are there lots of sheet marks? Because if there's lots of sheet marks, a lot of times after you wash someone, you would want to provide back care. You could give a nice back massage, get the blood flowing. You definitely want to check the sacrum, looking for any redness from laying on their back all the time. You want to lift up the folds of the butt cheek. You want to make sure there's no redness under there. You would provide care to the area, always checking, changing out a clean pad, changing out gloves. If they get soiled in any way, you could stop, do hand hygiene, and restart if you need to. So you would provide care back here. You would apply a cream, a barrier cream, if needed and warranted. You could use your judgment, and then we would roll the patient back over. We would ask them if they would like to help in their peri-care. That's very personal. Somebody might want to do that for themselves. If they don't want to, and as the nurse, you're going to provide perineal care. For the male, you would lift up the penis. If they weren't circumcised, you would pull back the foreskin. You would wash in a circular motion around the meatus and down the shaft of the penis. You would be switching out your wipe between each step. So it would be down the shaft of the penis, around one side of the testicle, the other side of the testicle, and one swipe down the back, always washing from the least contaminated to the most contaminated. And you wouldn't want anything from your rectum getting up near your urinary tract. You wouldn't want to have any type of infection. If it was a female patient, you would do the exact same thing. You would wash from side to side, always switching out your wipe. You would do around the sides of the groin. You would open up the labia, wash both sides, and then your final wipe would be right down the center. Again, not causing any contamination from your rectum into your urinary system. You would put on a clean gown, and then breakfast would be ready to come. You could provide your oral care prior to breakfast coming. If they have dentures on their bedside table, you would definitely want to wash and scrub the dentures like you would the teeth, and then you would want to put them in their mouth. You would want to raise up the head of the bed and preparing them to get their tray. All right, let's see. I'm forgetting. Some people, at this time, you would make sure they had their eyeglasses. You would put their dentures in their mouth, and you would put their hearing aids on. Now, hearing aids are put on in the morning, and in long-term care facilities, I'm not sure about hospitals, but they are removed at night and they are kept in the nurse's med box. We open up the backs to expose the batteries so that the battery lasts longer and they don't die. When the battery is closed, it makes a whistling sound in your hand. That's how you know that they are properly functioning. So you would set your patient up in bed. Their tray comes in. Depending on the patient, some people are independent, others not so much. They might need you just to do their coffee and their creamer, cut up their pancake. You always want to let people know what's hot. And I should state that before you do all of that, you are definitely checking to make sure that the identification on the tray matches with your patient. You want to make sure they're getting the proper diet. You wouldn't want someone who's on a mechanical soft or a puree diet to be getting solid foods if they have any choking problems. You definitely wouldn't want them to be given a thin liquid if they were supposed to be getting a thickened liquid or a nectar thick. So you always want to double check that it's the right patient, right meal, right diet before you set them up. Now that we have our patient all set up and they're prepared, if you have a visually impaired patient, you would even want to set up in the way of the clock. You know, your coffee is at 12 o'clock, your eggs are at 3 o'clock, so that they would know which direction which they're going. And if a patient is dissatisfied with what is on their tray, it is your job to see what else is an alternative for that patient. You always want to make sure that they're eating, and you want to document what's being taken in, as long as what is coming out, if that's warranted in this patient's case. After this patient is done eating, a lot of times that's when people want to do their oral care, at which time I would bring everything into the room. I'd have my emesis basin for spitting. I'd have my toothbrush, my toothpaste, and my mouthwash, and we would have the patient sit up. I would see how much they wanted to participate on their own. If they didn't want to, I would put toothpaste on the brush at a 45-degree angle. I would be brushing from the tooth up into the gum line, providing for breaks for spitting. At the end, we would provide for mouthwash. Even people with dentures may still want to use mouthwash before they put their dentures in. And if they are wearing dentures and they want them to come out to be cleaned, you would definitely make sure you put your finger in to break the suction before removing the dentures. Otherwise, sometimes it can get a little bit uncomfortable. All the while, when you're providing oral care, you're looking at the mucosa of the mouth. You're looking, is it pink? Is it moist? Are there any sores? A person that is wearing dentures, when you take them out, you can always slide your finger in there and feel around their gums, you know, see if it's okay. Could use a tongue depressor, look at the roof of the mouth, under the tongue, looking for anything that looks out of the ordinary that you didn't see yesterday. Any complaints? Are there any complaints of pain? Did anything hurt when you were swallowing? Is your uvula midline? Is your tongue midline? Is there any swelling on the tongue? Is there any cracking in the tongue? That could be a sign of dehydration. The whole time we are assessing. Every part of the body that we see, we're assessing. Okay, so we did the skin assessment and the oral assessment. So we're going to look at different ways that our patient is lying. So right now, my patient is in a supine position, but if we raised him up to like a 30 or 45 or even a 90-degree angle, that would be considered Fowler's position, and that is used a lot in times when people have some type of nasal drainage surgery or somebody who cannot breathe. We also have the orthopedic position, where you would set a patient up and there could be a bedside table that comes over their bed. They would put pillows on that. They would lay themselves across it. And this is good for opening up the airway. A lot of times in people who are having a hard time breathing, that would be a really good position for them. And a sideline position would be, as is stated, laying on one side or the other. And I should have pointed out earlier that when I'm putting a patient to lay on their side, I would be, if I'm going every 2 hours from side to side, I would pull my blanket, I would turn them to the side, and then I would position a pillow along the back of them right here. Now I know in school it's always lift from this side, but in nursing homes right now, you are not allowed to use side rails unless it is ordered by a doctor. It is considered a form of restraint. So in a nursing home situation, I would put my pillow here. I would come around the far side of the bed, and I would lift the patient from this direction. Simply because if there's no side rail here, your patient being older and they're afraid of falling for reasons of making them comfortable, I would grab my turning sheet and I would pull them this way, just so that you're there and you're reassuring them that they're not going to fall out of bed. And then I would provide my pillow. I would make sure that their shoulder is out from underneath of them, and I would reposition my pillow, and then I would move all their belongings to this side of the bed. Their call bell, their table, their water, their phone, their glasses, their books, anything that they need personally, I would then move to this side of the bed. And in a hospital setting, pull up the railings. In a nursing home setting, it is bed to the floor, floor mats in place, call bell with the resident at all times. Those are the safety measures that we carry out there. Okay, so let me see where I'm talking quite fast. So we would have our lithotomy position, and that would be if you were going to the OBGYN. The patient would be wearing a gown, and they would have a blanket across them, and they would have their feet in the stirrups. And that's that position for that. You also have your knee to chest when a patient is on all fours and their rear is in the air, and that would be for some examinations, maybe of the prostate. And then you have your prone position where patients are laying on their stomach, they're flat on their stomach. So we have this patient in a supine position, which is perfect because we're going to be changing his bedding in a minute. So while I have him in this position, we could check some of his pulses. His radial pulse would be found here, and his apical pulse would be found at the 5th intercostal space left of your sternum. Your pedal pulses would be found at the top of each foot, and your popliteal pulses would be located right behind your knee. Now, if there was a vast difference between your apical pulse and your radial pulse, that would be a sign of peripheral vascular disease, and that would have to be reported. Another thing that I could do while I was getting my patient ready in the morning is I could be providing all of my range of motion exercises as indicated by a physician or by physical therapy. Active range of motion would be range of motion that the patient is doing, such as like some would be like squeezing a ball in their hands. Some people have the resistance bands. They're doing your flexion and your extension with their feet. But if they cannot provide that for themselves, then you would be doing all of their flexion and extension, your adduction and your abduction. For a paralyzed patient, you would be doing all of those exercises. You could have the patient doing finger touches for coordination and for strength. Again, if they can't do it, you would be providing that for them. You would be doing range of motion for the upper and lower extremities if a patient was unable to participate in that themselves. Always being careful not to overextend any body parts. You never want to push a patient to a point where it's uncomfortable. So you would want to take it up. You would always be assessing for pain, and then you want to bring it back down. Even when you're moving patients and you have them moving their arms in, using side rails to come back and forth, these are all means of using range of motion. And you would always go by, again, what's ordered by a physician, by physical therapy, and you'd never want to push a patient past exertion. If they're tired, you would stop. Again, always assessing, and always documenting, because if you didn't document it, you didn't do it. So for this patient, he has had all of his morning care done. He's got on clean pajamas, he's eaten, we've done oral care, we've assessed all the skin, we don't see any areas of any problem, but he might want to have a clean bed. So in order to do that, we are going to ask him, would he like a clean bed? I'm going to utilize this sheet over again because I don't have another one of these. I would have all my supplies with me, and I would ask the patient to turn on his side this way. I would move the pillow over. I would be pulling up all the old bedding. Now mind you, I would be keeping the bedding. That could be soiled, sometimes you don't know what's in there. And I'm also being mindful of any personal belongings that may have fallen off. Sometimes you can find eyeglasses, hearing aids, dentures, personal belongings in there. So you're going to want to take all of your soil bedding and fold it deep under the patient, as far as you can get it. You're going to want to fold it all the way over there. Then you're going to want to take your fitted sheet. I don't fold mine like a hospital, so I would have it centered, the hospital blanket, fold top to bottom. I'm not sure how to professional launder sheets. You would do one side of the bed and then you would follow on the other. I'm going to pull it nice and tight. Nice and tight, nice and tight on this side. You only want to move one time over. So we are going to have our friction sheet going under there. I'm also going to tuck that under. And how long it is. This one is very short, but we would want to like tuck it under, make it really nice and tight. And then this is an actual hospital grade pad. And we would also want to tuck this under. After we finish tucking everything on this side, we would pull up our bed rail. We would move to the other side of the bed. We're keeping our patient covered. We would then have him turn that direction, grabbing onto that side of the bed rail. Again, he would stay covered the whole time because he wouldn't be a bear. We would move the pillow along with, fold up the dirty sheet. You want to fold everything inward, 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 inward and away. And then you would put it in the proper laundry basket, never on the floor, never touching your clothing. Then you would tighten up the bed sheet around all four sides, having our friction sheet available and our pad. And then you would have the patient come back to me. And then we would have this top sheet on. We would then cover him with a new top sheet, remove the dirty one from underneath, and then just have the new top sheet, which then, of course, away from our clothes into the trash can. We would hang this down. Our sheet would be up to here. We would then put on a bedspread that we would keep about 6 inches from the top, allowing us to fold this over and form a little bit of a pocket. And then when we put them together, at the bottom of the bed, the bedspread and the sheet, we would tuck them under. And then we would provide a mitered corner, 12 to 18 inches up. I would have the bedspread and the sheet both between my fingers. I would pull that up. And I would tuck it under, creating my mitered corner. And then I would ask the patient, do you want this tight around your feet? Do you like it tight? You want to be careful with patients with diabetes. You might want to loosen it up a little bit for them. Some older people don't like heavy things on their feet. They might not want the bedspread. They might just want the sheet. So you always want to be asking your patient what they want, not just maybe what is just standard. And then you would let the patient know you're going to be replacing them with a clean pillowcase. She would take off this pillowcase. Again, not putting it near your body. Throw it in the proper laundry basket. And then you would get your new pillowcase, put it in your hand, grab the end tightly, and then you would pull it down over your pillow, just like so. And I was taught, and I don't know that it's standard that you have to do it, but I always keep the open end away from the door. So it just looks nicer when people walk into the room. Okay, there we go. And I also could say that after we did AM care and did all the washing, if the patient needed to use any type of stocking, compression stockings or DVD stockings, that would have been the time that we would have put them on. Or even if they have to use the machine for venous blood flow, we would have put that on. And how we would have done that is I would take the sock and put my hand inside all the way to the heel and the toe. I would flip the sock inside out. I would then just put the sock part on my hand from there here to foot, and then I would roll the stocking up in a motion in that direction. And that would be helping the patient have good venous return from the periphery back into the heart, especially older people. Sometimes their elasticity in their arteries and their veins is just not there. It doesn't have the capacity to just give it that get up and go, and this helps to do that. If they were on a pump for DVTs, that would be attached to the end of their bed. I would make sure it was properly plugged in. I would put them on the bed, and then I would put the patient's foot in there. I would Velcro it from out to in, out to in. I would set the pressure on the machine, and I would hit start. After I'm finished all of these activities, I am providing hand hygiene, and I am documenting. So let's see if there's anything that I didn't get. Okay, I think we covered everything. If there's anything I missed, please feel free to let me know, and thanks for watching.